I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. My guest today is Dr. Troyen Brennan. Troy has sat in some of the most interesting seats in healthcare for understanding how to create affordable, high-quality care. He's been a primary care physician, a public health researcher, and the chief medical officer at CVS Health and Aetna. Thank you for being here today, Troyen Brennan. I'm very excited to have you. The reason I thought about having you do this with me is you have a new book coming out on primary care called Wonderful and Broken, which I think is a great title. But before we dig in, why don't you tell us a little bit about your career, what you've been doing?
Yeah, it's kind of a bifurcated career, Peggy. I started off as an academic. I was at the Harvard Medical School and the Harvard School of Public Health and did a lot of work on health policy, health law, medical injury, those kinds of things. And then I began to get involved in the hospital administration, eventually on the sort of senior team of what we then called Partners Healthcare, which was basically the Mass General and the Brigham combination in Boston. And I was doing that till the early 2000s. And then I switched over to the health insurance side. I went to work for Aetna for about 3 years. And then I went to CVS and we developed CVS into a much larger corporation, including a pharmacy benefit management company, and then bought the health insurer Aetna, established primary care clinics, had a lot of retail clinics. So in addition to the well-known retail pharmacy chain. So I like to look back on it and say I was sort of half in academic medicine and half in corporate healthcare.
You've sat in some of the most interesting seats in healthcare, especially as we think about what the healthcare system needs to look like in the future. I think you and I both agree that we're not getting our money's worth, to put it kind of crassly, for healthcare. We spend about twice as much as other developed countries. We don't cover everybody, and the cost is at least 2 times as high as the next highest country. And you and I and some of my fellow travelers here believe that value based care is an important construct. And I would also put with that population health, because ultimately the goal of healthcare is to improve the health of the people or keep people as healthy as possible at an affordable cost. And I don't think we're meeting either of those goals right now. And you got my attention with your prior book, which is called The Social Transformation of American Health Insurance, because you made the case that you think the employers are kind of fed up with paying for a healthcare system that they don't see as working well for them or their employees. And as you were thinking about healthcare reform in the future, you were trying to make sure we don't create another VA. I think you actually used the VA as an example. And if you didn't say that, you can correct me. So, can you just go down that road a little bit and talk about that before we get to the primary care thing?
Yeah, I spent a lot of time talking to employers and trying to sell employers health insurance services as well as pharmacy benefit management services. The people who run benefits for employers are very committed, thoughtful people. But I would say they're reactive more than proactive. There are some exceptions to that. But slowly but surely, the insurers and to some extent the pharmacy benefit managers have fewer and fewer tools to control the costs of care. The hospitals have gotten into a position where they're quite concentrated, and in most negotiations, they're going to win vis-a-vis the insurers. And so there's this constant pressure to increase the rate of payment above where Medicare was. So you and I can remember back in the day, commercial insurance rates were similar to Medicare. Now they're 2.5, 3, 4 times as high as Medicare. Most integrated delivery systems, the big health systems, they don't have any real strategy other than to get bigger and get better rates. You don't see them concentrating enough on how they can become more efficient. And the tools that the insurers have whether they be related to coding and down coding or prior authorization or to the negotiations they do, they're all getting less and less potent. So I think that what we're going to see, and certainly what we've seen in the last couple of years, is in continued inflation on the employer side. The employers are like the frogs in the boiling water that's heating up, going towards boiling. They're going to get to a point where they just feel like they can't afford this anymore. They may want to continue to sort of control healthcare, but they'll decide, I just can't afford these costs. And at some point, I think a Democratic administration will offer them an opportunity to get access to the government plans. The government plan's big benefit is that the government doesn't negotiate, it names what it's going to pay. And as a result, the Medicare payments are going to be a third of what the hospital's getting from its commercial payers. It just seems to me like a situation which can't persist. And then you layer on top of that the overall demographic changes in the country and the increase in the size of deficits. And I think it creates a situation in which you have to think about how the government plays a much stronger role in the financing of healthcare.
Yeah, thank you. That was a very clear exposition of some complicated ideas, so I want to thank you for that. I see your new book on primary care as emerging from this thought model because I think you make the case, and I believe this 100%, that primary care is a pillar of the value based delivery we need. And we're also at a moment when technology is enabling us to get from primary care, but the execution was very difficult because of the data that was available to the doctors or teams at the time they were delivering care. And there've just been a lot of breakthroughs on the technology side that I think will enable primary care to move its role up and be a partner to the whole entity that's trying to achieve best health outcomes at affordable costs, right? So we're going to shift now to talk about your book. Let me give you a moment to just lay out how you approach this. The book has so many interesting things in it, and I want to recommend it to people. But why don't you lay out the overall strategy and where you think we need to go?
Big picture, Peggy, you've done a good job of laying out what the foundation is. The only way you can see a healthcare system that works in the future is if it's value based, that is prospective payment and risk on the providers for the elaboration of the care that's going to be provided. If we believe what most people write about these things, we've got 25 to 30% waste as a result of the fee for service system. So if we move to a value based approach, that's money that's going to fund the system. That extra third that we can put back into real healthcare. So you need a value based approach. And then the second thing is, as you said, there's nobody who says anything other in health policy, at least, than that primary care should be the base of the healthcare system. They're not saying orthopedists should be, or pathologists, or cardiologists. Doesn't make any sense. You need a base where people have a reliable person who they can go to with their problems, who can promote their health and prevent illness, keep them out of the hospital, and keep them healthy. Everyone across the world who looks at healthcare agrees with that. So the book, the paradox of the title, Wonderful and Broken, is that this is what is supposed to be the foundation of what we're doing in healthcare. And yet, you talk to many of the people around primary care, those people providing care as doctors or nurse practitioners, and they're very unhappy. They feel very undervalued. They feel burned out. They feel like there's no support for primary care. And that's reflected in the statistics we have in this country. We probably spend in Medicare about 3.5% of the dollars on primary care, and in commercial, maybe it gets to be 4.5%, whereas many European countries are running between 10 and 15%. So the book is about how we can get to value based approaches in primary care with an eye to what could occur in the future.
Yeah, it's so ironic because we've designed the system to kind of punish primary care, and it shows in people's choices of what specialties they're going to go into. You didn't mention dermatology, but they're always one of my favorite examples. For some reason, we think that they really deserve to be paid a whole lot, even though you think about primary care, we're asking them to do a whole lot of care coordination and be the hub for, especially for complex patients, right? And yet we have them at the lowest end of the Medicare payment model, which is designed by a committee dominated by specialists. and where primary care has very little vote, let's put it that way. So our geriatricians, our pediatricians, and our regular primary care doctors are at the low end of the spectrum with the biggest jobs to do. It's funny because I can't think of an administration, even when Obamacare was being passed, that doesn't agree with the problem there. Yet we seem unable to fix it. There have been incremental projects with CMS trying to pay extra for advanced primary care. We ourselves have done patient centered medical home and had a good run with that model. I'm going to talk more about that later. But it's sad that our health policy, with all the smart people working on it, can't quite get out of its own way and make this happen.
Right.
So that's a comment. It's not a question. You can respond if you want to.
No, I agree completely with everything you said.
Yeah, thanks. So let's talk about why is primary care so critical to value based care?
Well, the original models of primary care really emphasize continuity of service and anticipation of problems and keeping individuals healthy. And in a value based approach, you would have the risk for illness on the providers. And so you need that kind of primary care base. You need someone who's basically overseeing the care plan for the patient, especially the sick patient, the patient with chronic disease, many of whom today in a fee for service approach just don't get the attention that they need because there's no incentive to keep those patients out of the hospital or keep them healthy other than the ethical commitment of the doctor to the patient. And that gets overwhelmed. In a fee for service primary care practice, you've got to see 15, 20, 25 patients a day to make ends meet because, as you said, the reimbursement levels that are set by the AMA's RVS Update Committee, so called RUC, are really quite low. And the statistic I like is that the time of a primary care doctor is valued at about 1/9 or 1/10 of what that is for a ophthalmologist. So there's just no room for taking the extra time necessary for patients who are very sick. But then you go to these value based practices that are taking, for example, a certain percentage of premium to take care of a population of patients. They will spend the kind of time that's necessary. They'll see 8 or 10 patients a day, and they'll make sure that they're taking every step possible to address patients who are really sick. And if I wanted to find a single sign of value based primary care, it's a meeting in the morning. All the providers get together. That is, their entire team, which includes nurses and case managers and pharmacists and physicians and nurse practitioners. They go over the sickest patients in the practice and they decide what steps need to be taken with those individuals. And they look at their statistics on how well they're doing with regard to outcomes that are important from the point of view of the patient's health. So that team meeting in the morning sets those practices off. When I see that occurring, I realize that's a group that's prospectively trying to anticipate illness and address it before patients get sick, which is what you need in a value based approach.
Yeah, that's great. That's called the huddle a lot of the time, right? Yeah,
Exactly.
yeah,
Yeah.
yeah, yeah. And the point about the statistics is important too, because when we wrote our patient centered medical home standards, they were more aspirational. And many times people did not have the information they needed to really execute on this model. And so I think we're at a moment when at least the potential is there for that team to have the data in front of them that they need to act proactively. And I just want you to talk about some stories about this. And one of the reasons I want the stories is I think, for example, people going on Medicare, they should want this because, especially if they have challenges with their health, this coordinated care presents an opportunity to keep them as healthy as possible. And I think people are worried about a depersonalized healthcare system. And I see the primary care doctor as also the face of that system. So I wonder if you could just tell us a few stories. And I know you're not trying to market for primary care, but I think people are distrustful of the healthcare system, and we have to overcome the paradigm that if it costs more, it must be better.
Hmm. Right. I think that's right. Well, one story I like is I was visiting with a young doctor who had just set up his practice in the suburbs north of Dallas. He was part of a much larger IPA, Independent Practice Association, that was promoting value-based care called Catalyst Health. We had a lot of the technology available from Catalyst Health. And the way he put it was his father was a doctor in a small town in Texas. And he said, 40 years ago, when you went to see my dad, you either call him up on the telephone or you were in his office. Those were his two points of access to information. And so paying him basically on the fact that he was seeing the patient made sense. Pay on a piece like we do in fee for service. But he said, today I'm in a situation where I've got information coming in from a variety of different sources. Maybe a nurse practitioner saw the patient, maybe a pharmacist consulted with the patient. The patient gets in touch with me through the electronic medical record, the portal approach. And I talk to the patient on the telephone, or I have a video visit. So it's just a huge platform of information that's coming into them. And it doesn't make any sense to be paid now on a piece when I'm just seeing that individual patient. I should be paid in a Netflix model where it's basically a certain amount per month, and that's for taking care of the patient. I thought that was very insightful. I'm also reminded, I saw that doctor in North Dallas, and what I thought was a very nice upper middle class suburb where he had set up his practice. I went 7 miles south into South Dallas, impoverished neighborhood where Baylor Scott and White had set up their wellness center, which was basically an outreach primary care practice that they were funding. The attitude of the doctors in that practice, even though 50 to 60% of their patients were uninsured and the rest were on Medicaid, whereas the practice in North Dallas all had commercial insurance, same set of assumptions about what patients needed and how to take care of patients. And their care managers, their outreach workers, were about 50% of their total employees. So they're spending a lot more time out of the clinic trying to gather information and keep track of patients. But both had this sort of same sense of looking prospectively to anticipate illness. And I think that's critical.
Yeah, that's great. I think you and I lived through a managed care backlash when the employers had committed to HMOs, they were fully insured. And when there were, let's say, overly enthusiastic attempts to rein in the costs, it's left people, maybe they started out with a bad attitude towards HMOs, but left people with a bad taste about these things. And so what you're talking about is those physicians and those care teams, they have a sense of the ethics of what they're trying to do. And this model enables them to do it better than the fee for service model, especially I use the rude term heads and beds model that exists where primary care practices are kind of feeders for hospitals. So I probably shouldn't say that, but that's kind of what I see. Anyway, why don't you go on and tell me about some of the other things that you saw or like your big takeaways for what needs to happen?
I would just go back to agree with you. Years ago, when I did public health school, at the same time I went to medical school, I had a hospital administration course, and we had an entire class on holiday parties. A big part of what you did as a hospital administrator was keep the physicians happy. And at that point, it was a matter of sort of keeping the ORs filled and the beds filled. That management strategy has not changed much till today. You still go into sort of management teams at hospitals and are still worried basically about the same things. They're not thinking about the overall health of the population. They're thinking about how I'm going to generate revenue by bringing patients. They're all well meaning, and many of them are non for profit, and they want to do the right thing, but these are the incentives in front of them. And I think you're also correct about the managed care backlash. You and I remember the Clinton health reform, which never really amounted to much, a big document, but there was never even a vote in Congress about it. It nonetheless had huge implications for healthcare systems because we all got very concerned that we were moving to a primary care capitated model and we didn't have control of the primary care. So we all went out and bought practices and brought primary care doctors on and integrated and got bigger. The mergers were based on the fact that we needed additional capital to be able to set for this new world. And then all of a sudden, like those of us in Boston, we realized, well, with all this, we actually have a lot more leverage over the insurers. And so we backed off of managed care and instead just went for bigger rate increases. And I was guilty as that as anybody else. I got our physicians at the partners organizations a 60% increase in their fees over a 3-year period in the latter part of the 20th century. Huge increases in payment for doing the same thing. And that's kept the fee for service system functioning. But There's been continued use of value based approaches. And I think Elliot Fisher and Mark McClellan did us a great service by changing the name from managed care to accountable care organization or value based approaches. It reiterates the point that you have to be thinking about how much these things cost because we only have a certain amount of money to put into the healthcare system. And then, as we've suggested, there is really no such thing as a value based approach without strong primary care. Another example I give, a place in Alaska that everybody told me to go to called the Southcentral Foundation, which is the large system for taking care of Alaskan Native American people around Anchorage. They basically operate a completely prospective system where everybody is assigned to a team. They're very much team based. Everybody has a primary care doctor. They're empaneled. So you're responsible for that patient. That's what empanelment means. And they also have care managers and pharmacists and nurse practitioners all working in the same place. They've designed their entire space to be able to promote this team based effort. They're doing this on the payments that come through the Indian Health Service as well as the Medicaid funds from the state of Alaska. So it's nearly completely sort of federal supported. And it suggests that you can have that kind of functioning system with outcomes that are really incredible. They've won the Malcolm Baldrige Award twice for the outcomes that they produce. It suggests it can be done. And I see a lot of places in federally qualified health centers which are pursuing a value based approach and providing excellent care with the statistics to show for that. So, overall, those things make me sort of heartened that this is possible and that it is percolating through the rest of the healthcare system.
Yeah. So I alluded to our patient-centered medical home program, which we started back in the 90s. And I feel very proud because a lot of practices transformed themselves into engines of prospective care management and population health. But as I said, I think that the true promise of primary care wasn't quite achieved just because there were information gaps at very important points. I wonder, did you see more technology enabled stuff that you think is critical for the future? We are doing a redesign of patient centered medical home with a tier that's called advanced primary care, and which will be looking for these kinds of things. So, what should we be looking for here? Maybe you can reflect on that for a minute.
Well, I do want to congratulate you for the work on the primary care medical home because the accreditation programs that NCQA put together really drove primary care. And I'd say
Thank you.
the PCMH program is one of the 3 or 4 major influences I point out in the 80s and 90s that actually began to sort of prepare primary care to do a value based approach. So I think that there's no understating the benefit that the healthcare system's gotten from the primary care medical home. And if it wasn't for the accreditation, I think it would have gotten nearly as broad in terms of its overall utilization. The better practices are aware of information from the patients that indicate when patients might be at risk. And I'm supportive of a number of private equity backed companies. Alade's like a good example from my point of view. You go to an Alade practice, they're concentrating on gathering information from the electronic medical record, processing that information, and then providing input to the physicians on who's at risk. So the better practices, the ones that are doing a better job, and the promise for the future is really in that analysis of the data and presentation of information to the care team. And then I was just sort of peeking around the corner because I did most of this road work 2 to 3 years ago. But already you began to sort of see how AI was starting to play a role to help address the avalanche of queries that come in through patient portals. It's great to have a patient portal if you're a patient, but it's hard on the practitioners to answer all those questions. And assisting them with artificial intelligence is going to be a big role. And then ambient listening. I talked to some doctors who said they shouldn't have made organic chemistry the critical course cause. They should have made typing the critical course because the electronic medical record turned us into typists. And now with ambient listening and development of the progress note by artificial intelligence, that's going to alleviate a lot of unnecessary effort on the part of the primary care doctor. So in many ways, I see some of the artificial intelligence promise in healthcare as really focused on primary care and making the job somewhat easier. But what you should be looking for in terms of the data is this analytic focus where you're providing the care team with messages about individual patients. And I think we're going to be able to anticipate more things, and that's going to make value based care a lot better.
Yeah, it's been so interesting to be part of this journey of primary care. In the beginning, I used to get really bad feedback from a lot of primary care doctors about the PCMH model and what a slave driver it was for individual practitioners. And it was like, you expect me to do all these things. And actually, the problem was the model also required a reorganization of the way the work got done, right? And teams. And especially in academic medicine places, that just wasn't thought through. You could understand why these people were crying out in pain. So I used to say what they really need is kind of some wraparound model. And Alidade came along and really started kind of really impressing all of us with what it is able to do in the ACO outcomes. Alidade enabled process. This is not a commercial for Alidade. Really, they excelled in the outcomes and the amount of money that got spent. There are other companies in that space, like Privia, I should mention. Even a truly committed healthcare system that really wants to move in to this risk-based model, they can do this kind of thing too. We would hope they don't all have to reinvent the wheel, but there's no reason it has to be an independent third party that's doing that stuff. It just feels so slow. I've been in my job for 35 years and I came in believing in this kind of value-based model. I had been a respiratory therapist, Troy, and I could not believe what I was seeing in hospitals. It was so awful. And it's why I decided I wanted to work on quality. And I wound up not in hospitals, but in this population health model. And it's so painful to get there. What are the things that should be happening? I think the current administration believes in this too. What should they be doing?
Yeah, the current administration, I look at it like one step forward, two steps back. They are looking at the rock and they are saying
Yeah.
they're going to stop using the sort of survey methodology and they put efficiency adjustments in place that should lead to 2 to 5, maybe even a little bit more percent increase in what you could pay for E&M codes. So that's all good. That's something that advocates, David Studdard, Zeke Emanuel, people have been writing about for years. Bob
Yeah.
Barron, probably the loudest voice. But on the other hand, they're going to gut a lot of practices. There's going to be a fifth of the federally qualified health centers that have to close down because once you took the double hit of no premium support in the exchange programs and the Medicaid cuts, there's going to be a lot of practices that can't make it. So
Yeah.
overall, I think it's probably a net negative. But in terms of what we can do, there was a big National Academy Award on
Yes.
Primary Care in
Yeah.
96 and then another one in 2021, sort of
Mhm.
25 years later. And they both said the same thing. And I don't think I come up with any recommendations that are a whole lot different than what they do. But they didn't suggest much hope or support, and they didn't find any basis for thinking that some of these changes are occurring in the healthcare system. So that's what I was trying to do.
Yeah.
I went to a number of practices which are pure fee for service practices, and I wrote about one of them at the University of Alabama. But my point was not to talk about how things are going bad, but where things are going well and how they're going well. And there's a lot of movement out there. So I'm like you. How long are we going to be shouting that this is the direction to go? But I am convinced that the tectonic forces in healthcare will require it, and that there is development of the mammals, even in this age of sort of reptiles, who are going to thrive eventually.
Okay, that seems like a great note to end on. As I reflect on my conversation with Troy, I'm struck by how clearly he lays out the challenges in American healthcare and how forcefully he points to solutions. His ability to connect the dots between policy, practice, and payment is unmatched. The way Troy explains these complex ideas is one of the clearest ways I've heard. His insights into the unsustainable trajectory of employer sponsored insurance and the urgent need for value based care are both sobering and galvanizing. What he offers isn't just critique, it's a roadmap grounded in real world examples, from Dallas to Anchorage. I'm grateful for Troy's voice, his vision, and his partnership in this long but vital journey toward better health care. I hope this conversation left you as energized as it did me.
Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.